All right, let's dive into the cardiac arrest algorithm. And look, this isn't just some textbook theory. This is the actual playbook for one of the most intense, high-stakes situations you'll ever face in medicine. When a heart stops, this framework is what gives you and your patient a real fighting chance. By the time we're done here, you're going to have a clear map to navigate this critical emergency with confidence.
So, picture it. You walk into a room, and your patient is just unresponsive. They don't react when you call their name, they don't move when you shake their shoulder, you immediately check for a pulse, and you feel nothing. This is it. This is ground zero. The clock has officially started, and everything you do in these next few seconds can literally change the outcome.
Okay, before you even think about jumping on the chest, before anyone yells clear, you have to be absolutely 100% sure. This first phase is all about confirming the arrest. In the middle of all the chaos of a code blue, this first step is your anchor. It makes sure you're fighting the right fight.
So what does that actually look like in real time? First, make sure the scene is safe, right? Then, you're checking for two things at once: breathing and a pulse. Look at the chest. Are they breathing normally? And listen, those weird agonal gasps, they don't count. At the exact same time, you're feeling for a carotid pulse. And here's the absolute key. You have no more than 10 seconds. If you're not sure after 10 seconds, you act. You start CPR. And while you're doing all this, you are shouting for help. A cardiac arrest is never, ever a solo mission.
So, the arrest is confirmed. Now your brain and your body should immediately kick in to a 3-letter sequence, CAB. Now, you might remember it being ABC for years, but that changed for a really important reason. In a patient with no pulse, blood flow is everything. Circulation comes first. That means chest compressions are priority number 1, period. Let's just walk right through it. C is for circulation. The very first person there starts compressions. Don't even hesitate. While that's going on, a second person can handle A for airway. Open it up with a simple head tilt chin lift. Then comes B for breathing, giving breaths with a bag mask. This whole sequence makes sure the most critical thing, getting blood moving, happens without any delay. But listen up, just pushing on the chest is not enough. It's high-quality CPR that saves brains. And that means you got to get the details right. You're aiming for a rate of about 100 to 120 per minute. Think of the beat to staying alive. You have to push hard, at least 5 centimeters deep. And this next one, this is what people always forget. Let the chest come all the way back up. That complete recoil is how the heart actually refills with blood. And finally, you have to swap the person doing compressions every 2 minutes. Fatigue is the silent killer of good CPR. Now let's zoom in on a skill that can be surprisingly tricky, the CE clamp. Honestly, getting a good seal with a bag mask can be one of the toughest things to do right in a code. The idea is pretty simple. Your thumb and index finger make a C shape to press the mask down, while your other 3 fingers make an E along the jawbone to pull it up into the mask. Getting this grip down is the difference between actually getting air into the lungs and just puffing it out into the room.
Okay, so high-quality CPR is going. You're buying precious time. Now the rest of the team starts arriving. With the monitor, the defibrillator, the drugs, this is where we shift gears from basic life support to advanced cardiovascular life support, or ACLS. And the ACLS algorithm, well, that's your roadmap through the absolute chaos of a code. It gives the whole team a shared plan and very clear decision points.
And this flowchart right here, I know it looks a little complicated, but it's really the heart of the whole thing. The second you get those defibrillator pads on the patient's chest, you see their cardiac rhythm. And you'll notice, right at the top, that one single piece of information, what is the rhythm, it forces a decision that sends you down one of 2 totally different pathways. Everything else you do depends on what you see on that screen. And that brings us to the single most important question you will ask during the entire code. Is the rhythm shockable? Your answer, a simple yes or no, dictates your very next action and sets the course for everything that follows. So let's break down those 2 paths. On one side, you've got the shockable rhythms, ventricular fibrillation and pulsus vitae. You can just think of this as pure electrical chaos in the heart. A shock is like hitting a giant reset button, hoping to get things back in order. On the other side, you've got the non-shockable rhythms, asystole, which is just a flat line, and PEA. In these cases, there's no electrical chaos to reset, so a shock would do absolutely nothing. For these, the only things that are going to help are perfect CPR and drugs like epinephrine. Okay, let's talk drugs. The number 1 workhorse for any cardiac arrest is epinephrine. You're going to give 1 milligram through an IV every 3 to 5 minutes. Doesn't matter what the rhythm is. Now, for those shockable rhythms that don't get better after the first shock, we bring in an antiarrhythmic. And our go-to first-line choice is amiodarone.
We start with a big 300 milligram bolus.
So the team is in a groove, they're running the algorithm, compressions, rhythm check, shock, drugs, repeat. But while all of that is happening, the person leading the code needs to have their brain on a totally different track, asking one question over and over: why? Why did this person arrest? Because if you can't find and fix the root cause, you're never going to get them back for good.
And the way you do that is with your mental checklist, the H's and T's. This is basically your list of reversible killers. So for the H's, you're thinking, are they hypoxic? Let's get them on 100% oxygen. Are they hypovolemic? Maybe from a trauma. We need to be pouring in fluids or blood. And for the T's, could it be a tension pneumothorax? That needs a needle in the chest right now. Or maybe cardiac tamponade. That needs a pericardiocentesis. Actively hunting down and treating one of these is so often the one thing that finally brings a pulse back.
Okay, so we've walked through the algorithm. Now let's talk about what really separates a good resuscitation from a bad one. This is all about avoiding the common mistakes and locking in those high-yield pearls that are going to make a difference, both in a real code and on your exams.
These right here, these are the cardinal sins of a cardiac arrest. The absolute #1 mistake, pausing chest compressions for too long. I mean, every single second that hands are off the chest, blood flow to the brain drops to 0. Other huge errors are CPR that's too slow or too shallow, forgetting to swap compressors and letting fatigue ruin your quality, or taking way too long to deliver that first shock for VFib. And finally, just getting so tunnel-visioned on the algorithm that you forget to think about the H's and T's.
So if you're going to memorize anything, memorize these pearls. For any pulseless patient, it is always CAB. The entire code runs on 2-minute cycles with a quick rhythm check in between. You have to know your drug doses cold, especially that first 300 milligram bolus of amiodarone. And here's a big one. Once the patient has an advanced airway, like an ET tube, the compressions become continuous. You give one breath every 6 seconds without ever stopping compression. Now let's say you did everything right. You shocked when you needed to, you treated one of the H's or T's, and during your next pulse check, you feel it, a strong carotid pulse. Congratulations, you have achieved return of spontaneous circulation, or ROSC. But the fight is not over, not by a long shot. In a lot of ways, it's just getting started.
Getting that pulse back, getting ROSC, it kicks off a whole new algorithm, a whole new set of priorities. The goal of post-cardiac arrest care is really simple: protect the brain. That brain has just been through a massive injury, so now we do everything we can to support it. That means we optimize their oxygen, we keep their blood pressure up to make sure the brain is getting good blood flow, we get an ECG right away to see if it was a heart attack, and very often we start cooling the patient down to lower their brain's metabolic demand.
Okay, let's put it all together into a final action plan. Here it is. First, you confirm the arrest and you yell for help. Then, you immediately start CAB, focusing on perfect, uninterrupted compressions. Get the monitor on and let the rhythm tell you which path of the algorithm to follow. Give your drugs on time every single time. And through it all, you keep that mental checklist running for the H's and T's. That's it. That is how you run a code.
In the end, I want you to remember this. The cardiac arrest algorithm isn't some rigid script that you have to follow blindly. It's a framework. It's what brings order to the chaos, what streamlines communication, and what makes sure the most critical actions happen on schedule. It's the tool that frees up your mind to think critically, to lead your team, and to give your patient the absolute best chance at life.